Hello, and welcome to this week's episode brought to you by VJOncology. In recognition of Liver Cancer Awareness Month, we're joined by leading experts who share the latest updates in immunotherapy, targeted therapy, and combination approaches for hepatocellular carcinoma. This podcast is available on the GI Cancer channel on VJOncology, an independent medical education platform which is supported by Takeda and Gilead Sciences. Supporters have no influence over the production of content. To begin, we hear from Stephen Lam Chan of the Chinese University of Hong Kong, who discusses recent advances in precision medicine for liver cancer, including novel immunotherapy targets such as TIM3 and TIGIT, and cytokine therapies targeting IL-27.
The current standard treatment for liver cancer is the doublet IO-IO, or the IO plus the VEGF. And of course, there are many studies and different thoughts on how to improve the treatment further. One is that we try to add some new targets. At this moment, I think the TIGIT is something that is being tested in the phase 3 setting. And of course, there's some other immune checkpoint inhibitors like the TIM3 that may also add on the immunotherapy. There are some studies showing that we may target the cytokines like interleukin-27. This may also be combined with the immunotherapy backbone and improve some of the response rate and survival. Apart from this, I think another potentially important is the FGF19-4 inhibitors. There's an abstract in the ESMO GI this year that when you combine with the atezolizumab, actually you do see, in those patients with FGF19 amplified HCC, you do see respectable response rate. I think this may also point towards some of precision medicine that we need to biopsy the patient to test some of the biomarker beforehand. So I think these are the three areas that possibly important in the future when we develop some new treatment for the liver cancer patients.
Next, Professor Lam Chan reviews findings from the phase 3b Sierra trial of durvalumab and tremelimumab in advanced hepatocellular carcinoma with poor prognosis.
The Sierra study is a phase 3b single-arm study looking at the first-line use of the steroid regimen in the HCC patient with adverse prognostic features, including those patients with Child-Pugh B function, or ECOG performance 2, or patient with main portal vein thrombosis, i.e. the VP4. There are two co-primary endpoints. One is the adverse events possibly related to study treatment, grade 3 to 4 within 6 months of time. Another co-primary endpoint is the overall response rate. So in the ESMO GI 2025, we presented the AE endpoint. In summary, those patients who developed the AE possibly related to the treatment within 6 months, grade 2 to grade 4, it occurred in around 19% of the patient. But a small number of patients stopped the treatment because of this AE, and only we see 2 patients who died from the AE in this study. And this is considered safe and manageable in this group of patients with adverse prognostic factors. So I think this provides very important data that for these patients who are sicker, who are not usually recruited in a clinical trial, they may also be safe to be treated with a steroid regimen.
He also addresses one of the major challenges in the clinic, managing immune-related adverse events.
We know that the immune-mediated AE, especially hepatitis, occurs in patients treated with immunotherapy. For grade 3 and 4, it occurs around 10 to 20% of the patient. And of course, for those patients who have worsening liver function, usually we need to start the high-dose steroid for those patients. One of the challenges that we are facing for patients with more suboptimal liver function is that they are prone to develop liver failure. Even we start promptly the steroids. So it remains a challenge that we need to identify the AE early and treat them aggressively. Another possibility is that usually for steroid treatment, it takes around 4 weeks, 6 weeks, or up to 8 weeks of time. During the time, the patient may have a progressive disease from the cancer. And if the patient already start with some poor liver function from the beginning, they also have a decompensation. And of course, this will lead to a suboptimal outcome, including death of the patient.
Moving on, we hear from Lorenza Rimassa of Unimed University in Milan, who discusses the CheckMate 9DW trial, comparing nivolumab plus ipilimumab with lenvatinib or sorafenib in advanced HCC. The combination has now become an FDA and EMA-approved standard of care, recommended in the latest ESMO guidelines.
versus lenvatinib or sorafenib, mostly lenvatinib, in patients with advanced stage HCC. The trial is positive, already published, and the combination of nivolumab plus ipilimumab has been approved by the FDA, by the EMA, is included in the ESMO guidelines, so it's a standard of care. The authors presented the quality of life data and also new data in terms of safety and efficacy. And it's important that 90% of the patients filled out the questionnaires for the quality of life analysis, both at baseline and during treatment. And another important point is that the authors used specific questionnaires that are specific for HCC, not general quality of life questionnaires. The results show that there is a clear benefit in quality of life for nivo-ipi compared to lenvatinib or sorafenib in terms of time to deterioration of quality of life that is much longer with the combination of immunotherapy compared to the tyrosine kinase inhibitors. Another aspect that they evaluated is how much patients are bothered by adverse events related to the treatment. And in the nivo-ipi arm, the patients are less bothered by the adverse events compared to the tyrosine kinase inhibitor arm. So this benefiting in quality of life. And the other important point, and the other important aspect that they presented the new data in terms of safety, the immune-mediated adverse events occurred mostly within 3 months of treatment initiation. And if we look at the liver and skin toxicity within the first month. This is an important piece of information for clinical practice because clinicians can know when they kind of see the adverse event, when they should expect the adverse event. So they should carefully manage patients within the first months of treatment initiation. And another important point is that the discontinuation of treatment due to treatment-related adverse events and the use of steroids to manage immune-mediated adverse events have no impact on overall survival. So there is no negative impact on overall survival. One point that is still not clear or not well explained in this trial is that the first part of the survival curve show a crossing. So in the first 6 months of treatment, there is benefit in survival from the tyrosine kinase inhibitor compared to nivo-ipi, and then there is a crossing. And it's not very clear what happened in the first part of the treatment, in the first months of treatment. And this is something that should still be investigated and should be clarified. But anyway, the trial is positive. This is a new standard of care, and the quality of life analysis support the use of nivo-ipi in clinical practice.
Next, Qi Cheng from Hwazong University of Science and Technology presents findings from a phase 2 trial of irpagratinib combined with atezolizumab in FGF19-positive advanced HCC.
The updated result from the 220 microgram BID cohort of irpagratinib in combination with atezolizumab are highly encouraging, demonstrating both robust efficacy and a manageable safety profile. The OR exceeded 50% in both treatment-naive and pre-treated HCC patients, surpassing the response rate of currently available therapies. The median PFS was 7 months in pre-treated patients and 8.3 months in treatment-naive patients, which is particularly promising in the context of FGF19 overexpression HCC.
We then turn to Ciro Celsa of the University of Milan, who reports results from the DT study, evaluating durvalumab with or without tremelimumab in unresectable HCC.
The TIM3 study is a multi-center study aiming to assess the safety and effectiveness of durvalumab plus tremelimumab for unresectable HCC. In this analysis, we enrolled about 233 patients with unresectable HCC, and we across different centers in all the world, and we focused our analysis in comparing the outcomes according to key inclusion criteria of Himalaya trial. So we stratified the population in Himalayan patients that are patients treated in first-line setting with child PUG class with a performance status of 0 or 1 and without PP4 portal invasion versus Himalaya outpatients. And basically we observed that patients classified as Himalayan, so strictly fitting the main inclusion criteria of the Himalaya trial, displayed a significantly better outcome in terms, especially of overall survival and also in terms of objective response rate. And from the point of view of the safety, both Himalayan and Himalaya outpatients show a good safety profile in absence of unexpected adverse events compared to the Himalaya trial results.
Finally, Marina Baretti of Johns Hopkins University School of Medicine shares results from a phase 1 study of a therapeutic vaccine targeting the DNAJ PKC kinase in combination with nivolumab and ipilimumab in patients with fibrolamellar HCC.
Yeah, so here at ASCO this year, we presented our results of a pilot study. It was a single-center, open-label pilot study of a novel peptide vaccine targeting the FLC fusion, DNAJ PKC, combined with the dual immune checkpoint blockade, nivolumab and ipilimumab. We enrolled patients that were age 12 and above who had a pathologically proven diagnosis of FLC. Their disease was to be unresectable for the purpose of the study, and they had no prior exposure to immune checkpoint blockade. And in our study, they received the vaccine in combination with an infusion of nivolumab and ipilimumab. Overall, we enrolled 12 patients that were evaluable for the endpoints of the study. And the main endpoint of our work was first to show the safety of this novel approach and this novel vaccine, especially when combined with immunotherapy, but also to see if we could elicit a specific anti-tumor immunity looking at the T-cell response against the fusion in the peripheral blood. Of the 12 patients that we enrolled, the median age was around 23, and the majority of patients had received the prior treatments, 1 to 4 prior line of therapies. In terms of safety, we found that this approach was very much safe. The most common vaccine-related adverse events were low-grade, usually injection site reaction, fatigue. And then some patients did have higher grade of toxicity from nivolumab and ipilimumab, but they all resolved with proper management. And we didn't see grade 4 or, higher type of adverse events. And in terms of the immunological endpoint, when we looked at them, T-cell response against the fusion, we saw that at baseline, only one patient had some T-cell response against the fusion, but after the vaccination, 75% of patients achieved this, immune recognition of the fusion, really suggesting that we were able to boost the immune system against the fusion as well. We also looked at the clinical activity. So again, these were pretty heavily pretreated patient population, but in the 12 patients that we treated, 3 patients had a deep and durable response that is maintained as of today. 6 more patients and a stabilization of their disease. So overall, the treatment was associated with a disease control rate of 75%. A big component of our study was to try to better understand what are the features associated with the response to the vaccine and the immunotherapy. And we looked at one of our responder and we looked at, circulate at the T-cell responses in this patient. And so we think that the next, one of the next avenue might be to use adaptive T-cell therapy in this type of cancer. But it's also clear that even though the majority of patients had some immune recognition of the fusion, not all of them had a major clinical responses. So we think that perhaps further modulation of the tumor immune microenvironment, perhaps targeting other component of the tumor microenvironment might be needed to elicit a better anti-tumor immunity.
Thank you for listening. We hope you enjoyed this special Liver Cancer Awareness Month episode of the VJOncology podcast.